ನಮ್ಮ ಟಿವಿ ಫೇಸ್ಬುಕ್ ಪೇಜ್ ನ ಲೈಕ್ ಮಾಡಿ, ಯೂಟ್ಯೂಬ್ ಚಾನೆಲ್ ನ ಸಬ್ಸ್ಕ್ರೈಬ್ ಮಾಡಿ. ನಮ್ಮ ಎಲ್ಲಾ ಯೂಟ್ಯೂಬ್ ವಿಡಿಯೋ ಅಪ್ಡೇಟ್ಸ್ಗೆ ಬೆಲ್ ಐಕಾನ್ ಕ್ಲಿಕ್ ಮಾಡಿ. ನಮ್ಮ ಟಿವಿ, ಕರಾವಳಿ ಕರ್ನಾಟಕದ ನಾಡಿಮಿಡಿತ.
ನಮಸ್ತೆ. ಯುನಿಟಿ ಹಾಸ್ಪಿಟಲ್ ಅರ್ಪಿಸುವ ಆರೋಗ್ಯ ಸ್ಪರ್ಶ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ತಮಗೆಲ್ಲರೂ ಆತ್ಮೀಯವಾಗಿ ಸ್ವಾಗತಿಸ್ತಾ ಇದ್ದೇನೆ. ಇಂದು ನಮ್ಮೊಂದಿಗೆ ಯುನಿಟಿ ಹಾಸ್ಪಿಟಲ್ನ ಕನ್ಸಲ್ಟಿಂಗ್ ಯೂರಾಲಜಿಸ್ಟ್ ಡಾಕ್ಟರ್ ಮುಜೀಬ್ ರಹಮಾನ್ ಅವರು ನಮ್ಮೊಂದಿಗಿದ್ದಾರೆ. ನಮ್ಮೆಲ್ಲ ವೀಕ್ಷಕರ ಪರವಾಗಿ ಡಾಕ್ಟರ್ನ ಆತ್ಮೀಯವಾಗಿ ಸ್ವಾಗತಿಸುತ್ತೇನೆ. ಡಾಕ್ಟರ್, ವೆಲ್ಕಮ್ ಟು ದ ಪ್ರೋಗ್ರಾಮ್.
ವೆಲ್ಕಮ್.
ಓಕೆ ಡಾಕ್ಟರ್, ಬೇಸಿಕಲಿ ಟುಡೇ ವಿ ಆರ್ ಟಾಕಿಂಗ್ ಅಬೌಟ್ urinary stones and prostate cancer.
Yes.
So let us focus more on prostate cancer.
Yes.
So what do you mean by prostate cancer, doctor?
Prostate is basically a small gland just below our urinary bladder.
Okay.
Basically what it produces is
You mean male?
it produces, it's in the seen only in the males.
Okay.
So it secretes some fluid, that is the prostatic fluid.
Okay.
That gives the liquefaction of the semen as well as reproductive some enzymes and all is coming from the prostate. Normally when a person is growing old, when the male hormones, when the action comes down, it should shrink and slowly the size of the gland decreases with as the sexually active period of the, like when it's beyond the say 55-60 years.
Okay.
So what happens is there are some conditions where you can get there's pathologically it becomes a malignant change. Some conditions it'll become big and block the urine output. So these are the issues basically with the prostate.
Okay. You're talking about, this is commonly seen in the old people. What common age group usually we find this prostate cancer?
Yeah, the cancer change, it can be from 40 years onwards. Usually if you keep on checking all the prostates, you can see the pathologically there may be some change in the prostate, but it may not be clinically evident.
Okay.
And patient might live with the cancer and might not die also.
Okay.
But some of the cancers of the prostate is there, like even though it's in the initial phases you diagnose, later on it might change in very aggressive form and there may be a rapid death for the patient. So in these kind of cases you have to keep a watch on the patient's symptoms, and if it has become symptomatic and all, like you screen or you test the for the prostate cancer, and if it's there then you can take treatment.
Okay. Usually who gets affected by this?
No, it's like in the Western world it's very common, and some of it is rapidly increasing also. In our country it was not much early, like maybe the screening was not with the advent of the more and more of literature and educative programs, and people are getting more aware to their health status. So the screened disease, like disease detected by screening, even it's increasing. So nowadays it's not like the number of cases being reported is increasing in our territory also, in this part of the country as well.
But do you find it in the early ages or?
No, it's basically like any other cancer is in the late phase of our, like once it starts, but the malignant change may be there, incipient for some time, and slowly it will become symptomatic, and usually it presents maybe like 55-60 and all, but earlier age also is seen. Family history also, like there are familial cancers are there. Suppose my brother has got some cancer, there is a chance increased at a young age, like more of chance for the other people to have like familial tumors chances.
But what's the usual symptoms of this disease?
Now, basically what happens is by the time you become 45-50 and all, slowly the patient will have some storage symptom, like he'll every now and then he'll feel like passing the urine, some sort of a lower abdominal discomfort, that incomplete sense of evacuation, so some sort of a pain after passing. Then night sometimes you'll have more of a frequency, like sometimes it will be very non-specific, but sometimes it will be like it will present in very advanced stage. Patient might come back with a trivial fall, he'll have a fracture, and sometimes the bone pain may be there. So sometimes maybe there's some small nodes, lymph nodes and all here and there. Those kind of presentations also is possible.
Okay. Is it very common in this part of the country, doctor?
No, now it's very common. Like it's not uncommon. Now it's like with the advent of the screening of and better awareness of the patients, like everyone is getting educated, health related, the awareness is increasing. So the reporting as well as the incidence is increasing, like in the Western world.
Okay. And usually how the diagnosis process takes place?
No, diagnosis basically when the symptom is there, and most of the time they'll go to the family physician, and prostate specific antigen one screen test is there. In that test what happens is you give the blood and immediately within 2 hours you'll get the test, and normally it's in our region it's kept as 0 to 4 nanogram per ml is the prostate specific antigen blood level, and if it's more than that up to 10 we'll say that it's slightly it's a gray zone, like you have to be careful. So suppose if it's more than 10, definitely you have to be very careful.
But usually the diagnosis stage starts with the blood test.
Yeah, blood test plus the symptoms. If it is some of the inciting like pre-monitory symptoms or some signs, they will be putting a digital regular examination will do, and clinically you examine, take a detailed history from the patient. Then with that you will come to a provisional diagnosis that this could be a cancer of the prostate. So in those kind of situations you can check further, you can transrectal ultrasound. Now we have multiparametric MRI scans are there. Then depending on the clinical, the symptoms of the patient as well as the radiological findings and all, you can better you can focus on to the narrow down your diagnosis onto the prostatic diseases, and you can go for a histological. And if you have any PSA is very high, now we have more of percentage pre-PSA is there, where you have the component of the PSA. Then again it'll tell you like there is a chance for more of a malignancy in this prostate. You can go for a ultrasound imaging. Then you take a biopsy from there. Biopsy confirmation is there, and depending on the stage and depending on the stage of the disease, you can take the treatment.
So like other any cancer, you say it is first stage, second stage?
Yeah, stages, the early stage. As I mentioned, this is all the grading of the cancer is there. Earlier it was like low grade tumors are there, like Gleason scoring system is there, grading system is there, 1 to 5 you grade, early phase 1 to 2 you don't have to worry, you surveillance, active surveillance. Patient might not die of the prostatic cancer, he might die of some other disease. So you don't aggressively over treat these kind of patients. So in this kind of patient there are different grading, there are different nomograms are there, whether the patient requires a treatment if he is diagnosed. You grade the disease, and if it's a high grade you have to definitely go for local staging of the tumor, whether it is locally advanced and if there is any, it's disseminated into some other areas of the body. Depending on that, investigative modalities are there. And being in the Western world is very common. The researchers and the amount of money that is being siphoned into this system is very, very huge amount, and lots of literature and the research work, and the treatments also day by day it's coming up from the Western world. Even though it was not very common, we are also actively searching and for these diseases, so that late manifestations as well as the morbidity and the mortality from this prostate cancer is now recently is decreasing because of the early treatment of the disease.
But how is the death rate because of this?
Death rate, if it is an advanced stage, the presentation if it is there, patient might die of prostate cancer. But it's early detected or is a low grade disease, the treatments are good and the patient's overall survival is very good. Death is very less, and patient might die, and some of the low grade tumors, and if you don't aggressively treat also, he'll not die of the prostate cancer. Little bit of symptomatology may be there. You actively watch the patient with a PSA screening, say in the initial phase, if it is a 4 nanogram, you do a complex PSA as well as the free PSA. So that will tell you like this patient requires a more aggressive follow-up. In those kind of cases, you see the biochemical or the kinetics of the prostate specific antigen, and there are different terminologies, like you have a PSA velocity is there, PSA density is there, So these kind of things, parameters you closely monitor, and if it is not a rapid increase in the prostate specific antigen, so you can just go on a slow, like once in 3 months you see that how is the progression. If it still is in the 4 or 4.5, if the kinetics is not rapidly going high, you can watch him with 3 monthly or 6 monthly. There are different regimes are there. If you consult a urologist, he'll tell you in what group, what sort of a monitoring you require. There are so many protocols are there.
Okay. Now, after the screening and diagnosis, usually what kind of treatment you start, or how the treatment will be started?
Treatment starts from the staging. First of all, you have to see the age of the patient, performance status of the patient, comorbidities associated with the patient. Comorbidity means sometimes the patient may be having some cardiac disease or lung disease or some other systemic illness, diabetes very high. He might be having that one more, might produce more of morbidity to the patient than per se this prostatic illness. So those kind of things, it is better to give a symptomatic management to the patient rather than going for an aggressive management protocol.
Okay.
So those kind of cases, you try to see the performance status of the patient, risk stratification of the patient. You put it in the poor risk, intermediate risk and the good risk. And if it is a good risk or those kind of thing, you stratify the disease depending on so many parameters are there. So based on that you can stratify the patient. Based on that you can early stage, suppose the investigative modalities, if it tells that is an early organ confined disease, is a like Gleason grade system 3, 4, 5. Those kind of cases you can, if it is a organ confined with an MRI, you go for remove that. That is the best. If you can remove it, that is the best thing you can do it. You remove it.
Doctor, we'll take a small break, and after the break we'll discuss with this. ಯುನಿಟಿ ಹಾಸ್ಪಿಟಲ್ ಅರ್ಪಿಸುವ ಆರೋಗ್ಯ ಸ್ಪರ್ಶ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಒಂದು ಸಣ್ಣ ವಿರಾಮ ತಗೊಳ್ತಾ ಇದ್ದೇವೆ. ತಮ್ಮ ಪ್ರಶ್ನೆಗಳನ್ನು 0824-240-6499ಗೆ ಕರೆ ಮಾಡಿ ಕೇಳಬಹುದು. ಅಲ್ಲಿವರೆಗೆ ಸಣ್ಣ ವಿರಾಮ ತೆಗೆದುಕೊಳ್ಳೋಣ. ಆರೋಗ್ಯ ಸ್ಪರ್ಶ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಮತ್ತೊಮ್ಮೆ ತಮ್ಮೆಲ್ಲರನ್ನ ಆತ್ಮೀಯವಾಗಿ ಸ್ವಾಗತಿಸ್ತಿದ್ದೇನೆ. ಡಾಕ್ಟರ್ ಮುಜೀಬ್ ರೆಹಮಾನ್ ಅವರು ನಮ್ಮೊಂದಿಗಿದ್ದಾರೆ. ಪ್ರಾಸ್ಟೇಟ್ ಕ್ಯಾನ್ಸರ್ನ ಬಗ್ಗೆ ನಮಗೆ ಇನ್ನಷ್ಟು ಮಾಹಿತಿಯನ್ನು ನೀಡಲಿಕ್ಕಿದ್ದಾರೆ. ಡಾಕ್ಟರ್, ಐ ಹರ್ಡ್ ದಟ್ ದೆರ್ ಆರ್ 3 types of treatments for prostate cancer. As you mentioned, surgical treatment. Can you put few words on surgical treatment?
Basically, there are different methods of treatment.
Okay.
Like you can have open surgery. You can have a laparoscopic surgery, you can have a robotic surgery. That
open surgeries in olden days, people used to do the surgery.
Yeah, it was olden times. Okay. Because even otherwise than non-surgical also there are lots of treatment like high intensity focused ultrasound.
Okay.
You can just burn that area.
Okay.
That whichever, it's like a small fruit or something. Like prostate is a small peanut like a lemon. It's a small thing, maybe some 17 to 22 grams. It's some area. It starts as a small rotten area in that area. That is the index lesion in there.
Okay.
So that lesion, if you can hit on that lesion initially itself, you can burn that area. That is the whole idea of treatment. So you have surgical treatment. You can irradiate that area.
Okay.
You can high intensity focused ultrasound. You can.
Okay.
You can. Erase that lesion, or else you can.
In surgical treatment, you said it's open surgery.
Yeah, open. Olden times, how it was like we were doing open surgery.
Okay.
You make an incision here, you dissect the whole area in that, then remove the gland. In toto, you remove it, you pluck it from there, and the surrounding area, whatever the lymph nodes and all there, you remove it. So those kind of treatment were there.
Okay.
Then morbidity associated, the pain associated, then the leak, then the hospital stay, blood loss, so many other, because suturing that area and all is extremely difficult. Okay. That was the problem. Then with that, the surgeons, they started innovative ideas. They wanted to see more and more of like newer, that was like a coalition or is a marriage between the technology with the skill of the surgeon. Okay. And there was lots of Eurotechnology work was going. So then then people were, the surgeons who were enthusiastic in this field, they wanted to minimize the the morbidity associated with the surgery, like more than the disease, the treatment was causing morbidity to the patient or huddle or strain to the patient's body. So they started newer innovative modalities like laparoscopic procedures, where you can put a keyhole.
Okay.
You put a hole into that, into the camera you put in that, you distance the area with the carbon dioxide or helium, then you have a better space there, you put small working ports, then under that the keyhole you can manipulate with you need special training for that, you do it, then the morbidity, but still the problems with the instrument, God has given us an endo wrist, we are able to move it like this. So this movement they were not able to make it with the laparoscopy. That was the trouble that was the facing. Then with that, the people started in maybe in 80s and 90s, people started getting training, but the learning curve for the surgeon was very long. They had to work for long to get trained and expertise in this kind of advanced laparoscopic surgery. So it was a tedious job, and still some of the areas, hidden areas were there. We were not able to put the sutures, ligatures because of the counterintuitive movement. Because the laparoscopy, what happens is when you move to this side, the tip of the instrument opposite side. So the surgeon needs lots of training, and the sisters, the assistants. It was a tedious job. They used to 3.5, 4 hours and lots of bleeding. Then came the robotic surgery in this field. Robotic, what happened is, this is an intuitive movement. You move your hand like this, the instrument also moves. You don't have to wash, you have to sit outside. There is a console is there. You can see the 10x magnification. There is a tremor filtration is there. Even though your hand moves like this, you can filter into 3:1, 5:1. That instrument won't move. Then the precision is there. Then 10x magnification is there. These are all the advanced, newer and newer development was there, but at the expense of a high cost of the treatment. This was this. So it became, people started believing more into the keyhole surgeries. So it became, and you could navigate the camera into the hidden area, that inaccessible areas. You can go into the inaccessible areas. Then you can have a 10x menu. It's as if you are going there and putting the stitch, and these are all the newer things, and it's coming in a big way, and the morbidity associated has come down. People have started getting less hospital stay, less of bleeding, and perfect surgery, less of positive surgical margins, and early recovery from the illness. So it's again coming in a big way, the robotic surgeries.
I was heard that you are the first robotic surgeon of Bangalore.
Yeah, I am the just the fellowship
Congratulations.
trained surgeon of Bangalore. Robotics.
What was your experience as a robotic surgeon?
Initially, when we started in establishing a robotic program, is very difficult. But once it's done, and once the learning curve of nearly 25 to 30 Ks are over, then it becomes very easy. Then you start loving the surgery, and it's an incremental. It's after say 10, 20 cases, it is an incremental. Your hand becomes more steady, and the result will be replicated into the patient's recovery as well as the patient's, the result also will be better.
And it's less painful for the patient.
Definitely is early recovery, and morbidity is very.
We are talking about the 3 types of treatments for prostate cancer, doctor. Now you explained about the surgical part.
More than
now medication part, what would you like to say?
Basically it's more than 3 treatments. Lots of other treatments are also there, and medications usually. If it's a localized disease, the best thing is you remove it. If it is locally advanced also, if you can remove it without a distance, like if it has not spread to other areas of the body, if you can remove it, the best thing you can do is you can do a surgical modality to treat it. Then medication, you basically, what we do, the medicine treatment is the hormonal. Basically the male hormone, the testosterone, is a nutrient for the prostate cells to grow, especially for the cancerous growth. So in those kind of, what we do, suppose you have a plant is there, you are giving water and all the fertilizers, the nutrients and everything, you withdraw the whole thing. Initially the cancer cells will shrink into a very small size, but later on what will happen, it will get independence and will start growing. So in cases where it has gone beyond the level where you can't surgically treat it or remove it from the body, in those kind of situations, the best thing what you can do is hormonally, because you give an oral tablet or an injection or a surgical castration, where the aim is to remove the testosterone, that growth, the nutrient to the prostatic cancer cell, you remove it. So the medications you can give, testosterone depriving the cells, like an LHRH agonist is there, LHRH antagonist is there. So like you can have monthly, 3 monthly, 6 monthly injections, and along with that you can go for a surgical, along with that a medical treatment along with that if you can give. It can, to some extent you can pull on.
Okay. But does it have some side effects?
Definitely it have early phase, because once the hormone, this testosterone is required for the day-to-day activities of the, it depends on the mood of the patient.
Okay.
It gives a musculoskeletal integrity, hematopoietic, like blood products, our generalized health, bone, everything is related to that.
Okay.
So once it comes down, once it is withdrawn from the body, so what will happen, the deleterious effects or the impact on the body will be there.
Okay.
So this can be like testosterone when once it's taken, because male, the macho figure or macho attitude of the people is because of the testosterone, because you are taking out all the testosterone, which is the nutrient to the prostate.
Okay.
So it will have definitely then impact. You can have a gynecomastia can be there, and drug-related sexual desire will come down.
Okay.
It has so many other premature, like it's an andropause you can get, like a menopause for the females, where everything will have hot flushes you can have. You will suddenly have sweating, and hypertension may be there, mood disturbances will be there. So many issues related to that.
Okay. You were talking about radiation treatment, doctor. What does it mean?
Radiation, especially if it is there are a few indications for radiation. What happens is one of the main problems with surgical treatment is there are the erectile nerves are going along the side, that like you have at 5 o'clock and 7 o'clock of the prostate. You have the erectile nerves going inside. That goes into the penis, the external genitalia. So when you remove it, that nerves also, there is a chance for removal of that.
Okay.
So the patient becomes erectile dysfunction can be there. So those kind of things, if we are too much worried about that, you can have the locally advanced early phases, surgery or radiation therapy, equally effective.
Okay.
Like a stage one, early, like a T1, T2 stages and all. Radiation is a very good treatment. You don't have to undergo the surgery, but
side effects
maybe more. Maybe more, like a patient will every now and then, maybe immediately it may not be there. 3 to 6 months later, it will have a very bad impact on the voiding pattern of the patient. You will be going to the toilet every now and then. My hematuria may be there, and so many issues. And another indication for radiation therapy is when you operate and there is a small area, there is a positive surgical margin. We call it the PSM. So if it's there, you can irradiate that. And now with the radiation therapy also has not like the external beam where you give it to a large area of the body. Now we have a focused area where you can hit on the target. Suppose you have that prostate is there, there is this is the malignant lesion, that is the index lesion. You can hit with that beam onto that. And now there are the brachytherapy is there. You can put the seed in that, over a period of time it will burn that. So it's also is a very good in the Western world, where the people are more worried about the erectile dysfunction of the patient. The radiation therapy is coming in a big way, but this one, you don't have a histological tissue for diagnosis. You will have to lifelong. Once it is removed surgically, you are happy that it's gone out of your body. Radiation therapy, still the lesion is there. It is burning that. It can come at, it's like it will get dampened. The effect of the activity of the lesion get dampened for some time, but later on it will become very, it can regrow with.
Okay, it's time for a small break now. So we'll come back to. We'll come back with some more details about prostate cancer and urinary stones. ಆರೋಗ್ಯ ಸ್ಪರ್ಶ ಕಾರ್ಯಕ್ರಮ ಮತ್ತೆ ಮುಂದುವರಿತಿದೆ ಒಂದು ಸಣ್ಣ ವಿರಾಮದ ನಂತರ. ಆರೋಗ್ಯ ಸ್ಪರ್ಶ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಮತ್ತೊಮ್ಮೆ ನಿಮ್ಮನ್ನು ಆತ್ಮೀಯವಾಗಿ ಸ್ವಾಗತಿಸುತ್ತೇನೆ. ಡಾಕ್ಟರ್, ಯು ಆರ್ ಟಾಕಿಂಗ್ ಅಬೌಟ್ ದ ರೇಡಿಯೇಷನ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಫಾರ್ ಪ್ರಾಸ್ಟೇಟ್ ಕ್ಯಾನ್ಸರ್. ಎನಿ ಅದರ್ ವರ್ಡ್ಸ್ ಟು ಬಿ ಟೋಲ್ಡ್ ಟು ಅವರ್ viewers regarding the radiation?
Radiation. Radiation
The side
is good.
effects, any side effects?
Side effects is basically the side effect of the radiation is it's like burning the tissue.
Okay.
So it burns not only that area of the cancer, it may be some little bit of collateral damage may be there, like side damage also. So because just behind is the rectum, in front, just above is the urinary bladder and urethra is there. So many other adjacent important exit points are there. So those kind of areas also it can get the impact of the radiation. But in a way, the organ preservation is happening at the cost of some of the deleterious effects of radiation. But in the Western world, it's more accepted because the erectile dysfunction is not there, it's minimal, although it's nil, it's there. But suppose you do a surgery and there is a positive surgical margin, you don't have any other, you can't go back again and you try to irradiate those areas. So it's like, it's not a single surgery, it's like a combination of treatment, multimodality treatment we usually give it to the patient. Ultimate aim is patient should get a relief or cure of the cancer by the like whatever available modality of the treatment with minimal of deleterious or treatment related bad ill effects to the patient.
Doctor, do you suggest any precautions for these prostate cancers?
Precautions, there are so many innumerable number of causes are mentioned, including the dietary, socioeconomic status, drugs, occupation, so many. But none of them are foolproof. Like if you don't take that food, it might. But these are all the genetically related now. More in the genomic profiling of the patient, there is a better understanding of the genetical abnormality, and it's going micro into the finer aspect of the disease.
Does lifestyle affect this disease?
Not
like,
much.
Those who sit for a long time.
Earlier we used to do Western diet, sexual life, so many other, but it's not 100%. But there are current recommendations are there in the basically in the Western, even though we are not strictly adhering to the screening protocol, like after 40 you every year or something you do the PSA, digital rectal examination and all those stuff.
So you mean to say early diagnosis would be better?
But if you have a family history, your sibling is having, or a strong positive history, if it's there, it's better to undergo a screening test and trust a transrectal ultrasound scan and all.
But do you suggest diabetic patients or blood pressure patients to have the
no, like there are literature saying that metabolic syndrome is related to the prostate cancer, is a relation. So those kind of people who has a predisposition to have malignancy of the prostate, is better to undergo a screening, because we have a good tool like prostate specific antigen testing, which is easily and freely available, that will to some extent will give you a which has got a better predictive value of like this person is maybe suffering from cancer of the prostate.
So the best treatment like robotic surgery treatment is also available in Unity Hospital in Mangalore?
No, we have a laparoscopic minimally invasive surgery in addition to the open surgery for cancer of the prostate.
I heard that you are the founder chairman of Prostate Care Foundation.
Yeah, because
what this foundation is doing?
Basically what happened was initially when we were studying the early phases, when we were in the college and all, it was a Western world disease. It was not very common, and later on we found, as we started interacting more and more with the prostate patient, we found that it is not very uncommon in this part of the country as well, and there is no, and I have seen many of my colleagues are having, even recently I have seen the death happening, my own colleague, doctor colleague with the CA prostate, and so many, and whenever you get a disease, and we have to look into the Western world, Western literatures, and some other neighboring countries, neighboring states, and neighboring cities, to get a detailed resources regarding the treatment and all. So with this idea in mind, we like-minded urologists, we started thinking about setting up a foundation so that we can give more and more resources, more and more suggestions and advice to, and whatever resources you, once you have a PSA is elevated, so how it has to be, the patient will be going to the family physician, they don't know what to do. So in those kind of situations we have made, like we are going into the, we are more into the patient care, giving to them resources, literature. Now we have into the research fellows are there. We are doing the research things and patient guidance. And there are the companies also, they are ready to do with the free PSA and drugs also to the patients who are suffering from this.
Okay.
With this idea in mind, we have started the prostate research for
Care
prostate
Foundation.
care foundation Mangalore. This is a registered body, and whoever wants the advice, they can call in by our number is there. It's a registered body. We are gathering that whoever has the disease or on treatment, what is the best mode of treatment, how the PSA, how often in the PSA has to be done.
Okay.
What are the recent drugs that is coming in them, and what is the efficacy of the treatment, we can guide them. And most of the advices, and it has got a website as well.
Okay.
So in that website the details are given. So these are all the patient related activities for. And parallel to that, educational activities as well as the research activity. That is the main motto or the objective of this prostate care foundation. That is first time in Mangalore we have started. That is has come into that it's a registered body. It is lots of academic activities we are doing.
So on behalf of all my viewers, this is the time to close the show. You have given us elaborated details about the prostate cancer, doctor, and we wish you a big success in this career. And on behalf of all my viewers and the NAMMA TV, thanks for gracing the occasion. ಮತ್ತೆ ವೀಕ್ಷಕರೇ, ಕಾರ್ಯಕ್ರಮವನ್ನು ವೀಕ್ಷಿಸಿದ್ದಕ್ಕೆ ತಮಗೆಲ್ಲರಿಗೂ ಶುಭರಾತ್ರಿಯನ್ನು ಕೋರ್ತಾ ಇದ್ದೇನೆ. ಧನ್ಯವಾದ.
ನಮ್ಮ ಟಿವಿ ಫೇಸ್ಬುಕ್ ಪೇಜ್ ನ ಲೈಕ್ ಮಾಡಿ, ಯೂಟ್ಯೂಬ್ ಚಾನೆಲ್ ನ ಸಬ್ಸ್ಕ್ರೈಬ್ ಮಾಡಿ. ನಮ್ಮ ಎಲ್ಲಾ ಯೂಟ್ಯೂಬ್ ವಿಡಿಯೋ ಅಪ್ಡೇಟ್ಸ್ಗೆ ಬೆಲ್ ಐಕಾನ್ ಕ್ಲಿಕ್ ಮಾಡಿ. ನಮ್ಮ ಟಿವಿ, ಕರಾವಳಿ ಕರ್ನಾಟಕದ ನಾಡಿಮಿಡಿತ.